Thank you, Dr. Mittal, and thank you to the chairpersons for this enlightening session. And now we'll move on to the next session. And before we start, I would request the chairpersons and the speaker to kindly adhere to the specified time limit so that we can stick to the schedule which we initially drew up. The next session is on polycystic ovary syndrome and obesity. And first, I'd like to invite on stage the chairpersons for this talk. The chairpersons are Dr. Poonam Gupta, Dr. Bansal, and Dr. Sweta. I would also request the three chairpersons to kindly introduce and invite the speaker on stage. Could we hand over a mic to the chairpersons, please? This has to be the most glamourful session of the conference. Please.
We have come to a very important topic, polycystic ovarian syndrome, which is a genetic syndrome aggravated by obesity. And in India, in some places, every fifth girl, 1 in 5 girls is affected by this. And to elaborate on this, we have none other than Dr. Surveen Ghumman, a very nice human being and a very close friend. She is very well known with 32 years of experience, and she's going to elaborate on polycystic ovarian syndrome with obesity.
Thank you. At the onset, I would like to state it's a pleasure being here, an honor speaking on this physician forum. I thank Dr. Paras, Dr. Naresh Tang, Dr. Rajiv Bansal, Dr. Makkar, and the rest of the team for having me over, and Dr. Poonam. Thank you so much for the kind introduction. So I have been given the task of speaking on PCOS and obesity, and I have tried to keep gynae to the minimum and make it more physician-based. We all know the definition. It's a wide spectrum from mild to severe with reproductive, endocrinological, and metabolic dysfunctions, and one of the most common disorders for women, prevalent in 6 to 10%. The diagnostic criteria, and why I'm taking it here, is because when she walks into your OPD chamber, you should be able to just point and say she is a PCOS. Irregular, infrequent periods, more facial hair, body hair, acne, or blood samples which are showing a high androgen level, and an ultrasound scan with more than 12 follicles of 2 to 9 mm or a higher volume. And the latest is that these follicles have been increased to 25 because of the high frequency ultrasound probe which we are using. There are 4 types of phenotypes. One is the severe one, which has all 3. The second is anovulatory, where there is anovulation and hyperandrogenemia. The third is ovulatory, where she's ovulating but there's hyperandrogenemia and PCOS on ultrasound. And the fourth is the mild one. But please note, obesity is not a part of criteria for diagnosis for PCOS. So how are we linking PCOS and obesity? Many years back, an obscure endocrine disorder known as polycystic came and took us by surprise, and then there appeared to be an epidemic of obesity and PCOS together. This common rise made us think that there is a cause or an effect relationship between obesity and PCOS. As women became fatter, they became more hirsute, and we thought, does obesity cause PCOS? Because if this is true, then we have found a prevention and a cure to PCOS by weight loss. But we ask ourselves that where is all this PCOS coming from, and what are we to do about it? So what does obesity do to PCOS? Well, obesity is definitely there in the PCOS women up to 80%, but it does not cause PCOS. It does modify the PCOS phenotype, especially metabolically and in reproductive medicines, causing infertility. So the impact of obesity on PCOS, what does it do? It increases the insulin resistance, increases compensatory hyperinsulinemia, which causes increased adipogenesis and decreased lipolysis. Obesity increases inflammatory adipokines, further worsening the condition, sensitizing the thecal cells to LH stimulation, causing upregulation of androgen production, and amplifying the functional ovarian hyperandrogenemia. Until recently, we thought that this was a hyperandrogenic disorder originating from the hypothalamic pituitary axis and the ovary itself. But now we feel that there is a metabolic origin and it impairs the reproductive function, and the various phenotypes are reinforcing this within us. So it is very important to disentangle this relationship between obesity and PCOS. So let's have a look at what insulin resistance does. Insulin resistance causes PCOS and it causes a metabolic abnormality leading to diabetes mellitus. There is a visceral fat which increases, and this visceral fat again causes PCOS and metabolic abnormality. And then there is hyperandrogenemia, which causes a premature puberty, again risk factor for PCOS. So there is this complex interaction between all these factors, and we feel that obesity exacerbates all these. So let's answer these questions to find out whether the egg comes first or the chicken comes first. Does obesity impact incidence of oligomenorrhea? That is one of the factors of PCOS. Yes, obese women are more likely to have irregular periods. What is the impact of obesity on incidence of PCOS? Girls who were overweight in childhood tend to develop PCOS more than those with normal weight in childhood. What about ovarian morphology on ultrasound? Yes, 61% of obese girls have that morphology, whereas only 32% of normal weight girls have that morphology. So again, what comes first? Let's see, can PCOS predict obesity? I'm talking about the other way around. Yes, in a study it was diagnosed that girls with PCOS displayed a much higher incidence of obesity compared to girls without PCOS. Can PCOS cause obesity? Hyperandrogenemia may contribute to the visceral adiposity, thus modifying the fat. Hence, the relationship between PCOS and obesity is complex, it is not well understood, and it most likely involves the interaction of genetic and environmental factors. The other side of the argument, they say that there is no connection. The association between adult obesity and PCOS is inconclusive, and hence it is not a part of the diagnostic criteria. And why is that so? Because they found especially that in certain populations the PCOS is at a certain level and constant, but obesity varies and has ethnic differences. Hence, these studies illustrate that obesity and PCOS are correlative in their pathogenesis and suggest that the detection of either of them is a high risk factor for long-term health risks. So that is why it is important to differentiate metabolically healthy PCOS from metabolically unhealthy PCOS when they walk into your OPD chamber. We all know about the metabolic syndrome. I am in a physician conference and I am not going into that, but this was a very recent paper of November 2021 which tended to differentiate the metabolically healthy PCOS who had a worse body composition and a hormonal and metabolic profile which was adverse. The long-term consequences in these patients were, of course, diabetes, gestational diabetes, cardiovascular complications, sleep apnea, and endometrial hyperplasia leading to endometrial cancer. So these are the long-term consequences. The strategies for risk reduction were diet, exercise 30 minutes aerobic, weight loss 5 to 10%, and this weight loss tended to decrease the insulin resistance and the testosterone levels. And hence, when this basic dietary modification and lifestyle modification did not work, we needed a structured weight management program with a multidisciplinary approach, which included the gynecologist, physician, dietitian, and psychologist. If that failed, we needed pharmacological management, and I'm not going into that because I think you would know that better than me. I generally tend to refer them. But metformin is one of the drugs we use for a clomiphene resistant obese PCOS. The new drug on the block is GLPA-1 agonist, which has come into play very recently. We are using it in infertility. We do a pre-treatment with liraglutide, and it has a dual advantage of weight loss and testosterone reduction, mixed results to improve insulin resistance, but it is specially indicated in assisted reproductive settings when women are seeking help for infertility, and it helps to decrease the risks of ovarian stimulation and pregnancy by minimizing them through a weight loss. The more recent concept which we are going into is microbiota and PCOS. So it has been seen that the microbiota, both of the gut as well as of the vagina, are important in the pathogenesis of PCOS, and probiotics help to improve the intestinal, digestive and absorptive functions of the nutrients. Bariatric surgery is another one which is important, and it is only indicated in PCOS women of BMI of more than 40 or 35. Obese PCOS and fertility, we tend to get anovulatory infertility, they hyperstimulate, poor egg quality, poor fertilization, and the patient is like this and we are like this. And what we need is a good general physician to make us like this. How is the primary care physician important in for the fertility specialist? When you take a history in your chamber and you send her for an ultrasound and diagnose a PCOS, you can put her on a weight loss regime right away, making the ovaries more sensitive and making us get a better result with our ovulation induction regimes and making us happy. There are huge mental health issues and I'm not going into them, but yes, you can change your perspective and deal with those mental health issues. There is great need for research into several issues regarding the complexity of PCOS and their true negative impact, but the real challenge is going to be that after we acquire this evidence, how do we adopt safe strategies in protecting women's health all her life? This is a critical public health issue and we need to stratify women according to their metabolic risk, and we need to bring together a preventive medical strategy for the PCOS women. Treatment without prevention is simply unsustainable, as Bill Gates said. Hence, prevention must start in adolescence for these PCOS women. Thank you.
So, thank you, madam. It was a wonderful outlook of PCOS. So, one question even I want to ask before we open the session. We are finding a lot of incidental finding during the people who are coming for the health checkup, or now the girls who are coming for the pre-employment sort of the checkup. So they might not be obese, but the PCOS is, incidence of the PCOS is very, very like you can find every second girl having the PCOS. What's your take on this? Should they be
So there are
treated?
two things. One is that yes, we are diagnosing better, and second is we are diagnosing wrong.
Wow.
Often, we diagnose just on ultrasound finding, and there are no two other this thing. So she's just labeled from the ultrasoundologist chamber that okay, PCOS is the diagnosis written on that
Community medicine.
ultrasound. So we could be
But
over-diagnosing
we
these
can-
patients, but yes, there is an epidemic which is occurring. Maybe what I've written about the gut microbiota being responsible, quite possible a bad lifestyle, maybe the reason. And the reason why I put that slide there was because they don't come directly to us. They will come to the physician with various problems. And if they could be treated right there with their weight problems and their metabolic problems, we would be better able to deal with them when we do an IVF or we do a basic infertility treatment.
Definitely. And once we diagnose these girls with PCOD, they should be actually, subjected to a lot of biochemical other tests, like lipid profile and sugar profile. So many of them would have actually would be having a deranged OGTT.
So I could, make this presentation for 1 hour. I just cut it down. Otherwise, I have slides with everything there. There was a huge lot of investigations, when to do, who should be screened, why to screen, but I didn't do it because of paucity of time.
I'll just ask you a very simple, practical question. We all say reduce weight, and you also said reduce 5 to 10% of weight. Is it a dogmatic thing, you reduce 5 to 10%, or there are any clinical, biochemical, radiological features which tell you how much a girl should reduce?
So 5 to 10% has come from us reproductive people. because we found that the ovaries start responding after a 5% reduction in weight. In fact, we found that ovaries start responding just when she does aerobic exercises, even if she doesn't lose weight. So that 5% is there so that she loses a little bit of weight through exercise, which helps us. Mainly the aerobic exercise which helps.
I think, thank you very much. So it was a take-home message. We are running short of the time. I don't know whether the organizer will allow any question. But I think the take-home message is, again, which we are talking since morning, the lifestyle, and lifestyle. How you are managing your eating, your exercise schedule, and your psychological aspect. So all important for even the PCOS as well as for the obesity. So I think
one of the most difficult things for a PCOS is to lose weight. We tell them, they come back the same weight. So there has to be some kind of a, multidisciplinary approach for this with a psychologist, physician, otherwise they don't do it.
Yeah.
Obesity leads to PCOD. It's a vicious circle actually. Obesity leads to PCOS and PCOS doesn't let you lose weight.
And it also leads to depression and depression leads to eating. This is the vicious cycle.
Multidisciplinary approach to a girl.
So thank you very much. Thank you, madam.
Thank you.